Warm greetings to Mrs.S.Pauline Sheela Priya, Assistant Professor, Faculty of Sri Balaji College of Nursing, Bharat Institute of Higher Education and Research, Chennai. So today we are going to discuss an important topic in pathology, that is pathological changes in renal system. So structure of the kidney. So the paired kidneys lie on either side of the spine in the retroperitoneal space between the parietal peritoneum and the posterior abdominal. It is well protected by muscle, fat, and ribs. The left kidney is located at about the T12 to L3 vertebra, whereas the right is lower due to the slight displacement by the liver. So upper portions of the kidneys are somewhat protected by the 11th and 12th rib. Each kidney weighs about 125 to 175 grams in males and 115 to 155 grams in females. So they are about 11 to 14 centimeter in length, 6 centimeter wide, and 4 centimeter thick, and are directly covered by a fibrous capsule, which is composed of dense, irregular connective tissue that helps to hold their shape and protect them. So this capsule is covered by a shock-absorbing layer of adipose tissue called the renal fat pad, which is in turn encompassed by a tough renal fascia. So the fascia and to a lesser extent the overlying peritoneum serve to firmly anchor the kidneys to the posterior abdominal wall in a retroperitoneal position. So blood supply of the kidneys and nephrons. So the kidneys are well vascularized and receive about 25% of the cardiac output at rest. So blood enters the kidney via the paired renal arteries that form directly from the descending aorta, and each enters the kidney at the renal hilum. So once in the kidney, each renal artery first divides into segmental artery, followed by further branching to form interlobar arteries that pass through the renal columns to reach the cortex. The interlobar arteries in turn branch into arcuate arteries, cortical radiate arteries, and then into afferent arterioles. So the afferent arterioles deliver blood into a modified capillary bed called the glomerulus, which is a component of the functional unit of the kidney called the nephron. There are about 1.3 million nephrons in each kidney, and they function to filter the blood. So once the nephrons have filtered the blood, the renal veins return the blood directly to the inferior vena cava. A portal system is formed when the blood flows from the glomerulus to the afferent arteriole through a secondary capillary bed, the peritubular capillaries surrounding the proximal and distal convoluted tubules, and lastly the loop of Henle. So most water and solutes are recovered by this second capillary bed. This filtrate is processed and finally gathered by collecting ducts that drain into the minor calyx, which merge to form major calyx. The filtrate then proceeds to the renal pelvis and finally the ureters. So you can see the renal vein, renal artery, renal calyx, medullary pyramid, renal cortex and segmental artery, interlobar artery, arcuate vein, interlobar vein and segmental vein, and finally you can have the renal pelvis and ureter. So moving on to the disease, that is renal disease. So 20% of the women get urinary tract infection. So the renal diseases are divided for analytical purpose. It is divided into diseases of the glomeruli and diseases of the tubules, interstitium, and vessels. So renal disease are classified into 4 major classifications: diseases of the glomeruli, diseases of the tubules, and diseases of the interstitium, and diseases of the vessels. So first one is glomerular disease. So glomerular diseases tend to be immunologically mediated. So tubular and interstitial disorders are often due to toxins and infections. So glomerular and tubular disease affect each other because glomerular disease impairs the tubular blood supply and increase the tubular toxins, and tubular disease causes increased intraglomerular pressure. Uremia. So azotemia plus clinical signs and symptoms, that is gastroenteritis, peripheral neuropathy, fibrinous pericarditis, secondary hyperparathyroidism, which are associated with chronic renal failure, that is termed as uremia. In tubular defects cause polyuria, nocturia. Polyuria is excess amount of urination. Nocturia is nighttime urination. And electrolyte disorders due to diseases directly or indirectly affecting the tubular function. So next is acute nephritic syndrome. So acute nephritic syndrome, there is a gross visible hematuria, hypertension, azotemia, oliguria, mild edema, red blood cell cast, and variable proteinuria. So which is associated with post-infectious glomerulonephritis, early lupus, diffuse, crescentic, and membranoproliferative glomerulonephritis. In short, so acute nephritic syndrome, major symptoms are gross hematuria, that is sudden onset, and then the patient will have edema, hypertension, and renal insufficiency, that is oliguria. So next one is acute renal failure. So abrupt anuria or oliguria with rapidly progressive azotemia is identified by increased in BUN, that is blood urea, nitrogen, or ammonia. Azotemia, so increased serum BUN, that is blood urea, nitrogen, and creatinine due to reduced GFR. So GFR is nothing but glomerular filtration rate. So the causes of acute renal failure are divided into three: pre-renal, renal, and post-renal. So in pre-renal, the major causes are hemorrhage, shock, congestive heart failure, volume depletion. In post-renal, we have obstruction. So causes of acute renal failure. So in pre-renal, there will be a sudden and severe drop in blood pressure, especially in the shock, or interruption of blood flow to the kidneys from severe injury or illness. Intrarenal, so that within the renal, that is direct damage to the kidneys by either inflammation or toxins or drugs, infection, or reduced blood supply. In post-renal, sudden obstruction of urine flow due to enlarged prostate, kidney stones, bladder, either in the tumor or injury. So these are the causes of acute renal failure. Chronic renal failure. So when the azotemia is progressing to uremia over a period of years, that is known as chronic renal failure. So there are 4 stages of chronic renal failure. So diminished renal reserve, that is the glomerular filtration rate is 50% normal with normal BUN and creatinine. That is known as diminished renal reserve. The second one is renal insufficiency. The patient will have azotemia, anemia, hypertension, polyuria, and nocturia. That is, the patient has started the symptoms of azotemia, anemia, hypertension, polyuria, and nocturia. That stage is known as renal insufficiency. So renal failure, when the glomerular filtration rate is less than 20% is normal, then kidneys cannot regulate the volume of the solutes and the patient develops edema, metabolic acidosis, and hypocalcemia. Then the last stage is end-stage renal disease. That is, only the GFR is less than 5% of the normal and represents the end stage of various renal disease. So totally we have 4 stages: diminished renal reserve, renal insufficiency, renal failure. Finally, we have end stage renal disease. So in chronic renal failure or renal insufficiency, the major symptoms are the patient will have headache, then decreased ability to concentrate urine, polyuria to oliguria, then increased level of BUN and serum creatinine, and the glomerular filtration rate is progressively decreased from 90 to 30 ml per minute. The patient will have mild anemia and increased level of serum potassium, then increased in blood pressure, weakness, and fatigue. The next condition is nephrotic syndrome. So nephrotic syndrome is a trait of hypoalbuminemia, proteinuria, and edema. So these are 3 major symptoms in nephrotic syndrome: hypoalbuminemia, proteinuria, and edema. So proteinuria, so more than 3.5 grams per day. Hypoalbuminemia, the serum level is less than 3 grams per deciliter. The patient will exhibit hyperlipidemia, lipiduria, and severe edema. Throughout the body, there will be edema that is known as anasarca. So due to dearrangement in the glomerular capillary walls, which leads to increased permeability to plasma proteins, causing massive proteinuria, microhematuria in 50% of the hypoalbuminemia, and generalized edema. That edema will be a pitting type in the periorbital and dependent edema. Hypertension in up to 25%, and the patient will have thrombotic tendency. Hyperlipidemia is due to increased lipoprotein synthesis and decreased catabolism. So because of the increased lipoprotein synthesis and decreased catabolism, there will be increased level of lipids in the blood. Then lipiduria is due to leakage of lipoproteins with albumin. So in nephrotic syndrome, the patients are prone to get staphylococcus, pneumococcal infections due to loss of immunoglobulins and factor B of complement. So thrombosis and thromboemboli are due to loss of anticoagulants such as antithrombin 3 and antiplasmin. So it is associated with minimal change disease. It is more common in children. The focal and segmental glomerulosclerosis, membranous glomerulonephritis, which is more common in adults, and it is systemic diseases like SLE, systemic lupus erythematosus, diabetes, amyloidosis, and congenital nephrotic syndromes. So the causes of nephrotic syndromes are usually unknown, maybe immunological, and SLE, that is systemic lupus erythematosus, maybe genetics, drugs, infections, diseases like diabetes, amyloidosis, malignancies, and then. So these are the certain causes for nephrotic syndrome. The glomerular disease. So under the disease, we have glomerulonephritis, that is inflammation of the glomerulus, glomerulopathy, any disorder affecting the glomerulus, that is known as glomerulopathy. So primary glomerular disease. The kidney is only a predominant organ involved. That is known as primary glomerular disease. And changes can be diffuse or all glomeruli, or it may be a focal. If it is a global, that is the entire glomerulus, or segmental, that is part of the glomerulus, or mesangial. Minimal change disease or diffuse mesangial hypercellularity and focal and segmental glomerulosclerosis may be a continuum of the same disease. So EGFR pathway may be the new therapeutic target in glomerular disease. So glomerulonephritis. So due to antigen antibody complex from the recent streptococcal infection, there will be an antigen antibody complex in glomeruli causing an inflammation and decreasing the glomerular filtration rate. So the main symptoms are the patient will have headache, then increased level of blood pressure, facial or periorbital edema, feeling of lethargic, low-grade fever, weight gain, and then patient will exhibit the symptoms of edema. Along with that, the patient will have proteinuria, hematuria, oliguria, and dysuria. So, pathogenesis of glomerular disease. So, usually the immune mediated via antibody deposition, cell mediated injury, or activation of alternative complement pathway. So, the antibodies deposited are either to in the situ antigen, intrinsic or planted, or circulating the immune complexes. So, intrinsic, that is good pasture disease antigens are the basement membrane. Hayman nephritis antigens are on visceral epithelial cells, which produce a linear immunofluorescent pattern. Planted antigens are deposited in the basement membrane. It may be exogenous, like drugs, infectious agents, or it may be endogenous, like DNA, immunoglobulin, or immune complex. Their cationic proteins bind to the glomerular anionic sites and produce granular, lumpy staining by immunofluorescence. So circulating immune complexes, it may be endogenous, DNA or tumors, or it may be exogenous, that is infectious products. They usually localize within the glomeruli and activate the complement. So the deposits are usually mesangial or subendothelial and resolved by macrophage phagocytosis unless they are repeated cycles of formation in hepatitis B and C and lupus. So it's a cell-mediated immune injury is by sensitized nephritogenic T cells. So progression to end-stage renal disease occurs when the glomerular filtration rate, that is GFR, is 30 to 50% of the normal, and due to compensatory hypertrophy of the remaining glomeruli and systemic hypertension, which is inhibited by angiotensin converting enzyme inhibitors, eventually causing glomerulosclerosis. So the micro description shows injured epithelial cells have vacuoles, retract and detach from basement membrane and lose the food process. In immunofluorescence description, it shows granular deposits represent immune complexes that settle out of blood or form in situ. Linear deposits are due to anti-basement membrane antibodies or light chain nephropathy. It can detect via fluorescent antibodies or using some fluorescent microscopy of H&E stain sections fixed in Hollandy fixated. Chronic glomerulonephritis. An end-stage disease, it is due to progression of various types of glomerulonephritis. Occasionally, no prior history of kidney disease. The rate of progression is, it is rapidly progressive in 90% of the population, and post-streptococcal infection seen in 1% in children and 5% in adults. So focal and segmental glomerulosclerosis, 50 to 80% rapid, and membranous will be 50%, and membranoproliferative is 50%. Then immunoglobulin A nephropathy can be seen in 30 to 50%. It's very a slow process. So rates of progression varies according to the age group. Paradoxically, nephrotic syndrome symptoms decrease as glomeruli disappear. So the gross description shows symmetrically the small kidneys with thin granular cortex and increased peripelvic fat. So micro description shows the glomerulosclerosis, tubular atrophy and thyroidization, interstitial fibrosis and lymphocytic inflammation, arterial and arteriolar sclerosis. So till now we have finished the diseases of the glomerulus. Moving on to the tubular and interstitial disease. So primary tubulo-interstitial disease, that is nephritis, lacks significant glomerular or vascular injury, causes 20 to 40% of the cases of end-stage renal disease. whereas the secondary tubulointerstitial nephritis is due to glomerular disease, systemic or vascular disorder. Staining is recommended to identify the subset with immunoglobulin G4 related disease. So tubulointerstitial disease may be acute, seen in interstitial edema, neutrophils, focal tubular necrosis, or chronic, that is mononuclear inflammation, interstitial fibrosis, and tubular atrophy. So the main symptoms are inability to concentrate urine. Patient might have polyuria or nocturia, salt pasting, and diminished ability to excrete the acids, resulting in metabolic acidosis. So the main causes are infections, jejunal-ileal bypass, or metabolic disease, toxins, tumors, vascular disease, or immunoglobulin G4s. Acute pyelonephritis. So it is a common suppurative inflammation of the kidney and renal pelvis. So the main etiology or causes are bacterial infections, commonly Escherichia coli. Others include Proteus, Klebsiella, Enterobacter, and Pseudomonas, causing recurrent infection. So the route of entry is hematogenous infection. So seeding of the kidneys by bacteria in septicemia or in infective endocarditis. Example, Staphylococcus ascending infection. It's a more common bacteria from the lower urinary tract, as in cystitis, prostatitis, urethritis, which is ascending to the kidney. So pathogenesis of the ascending infection. So bacteria will adhere to the mucosal surface and colonize the distal urethra and gain access to the bladder by expansive growth of colonies, outflow obstruction, and increased residual volume of the urine stasis. The bacteria is multiplying and ascending along with the ureters to the renal pelvis. Vesico-urethral reflex allows the infected urine to ascend into the renal parenchyma through open ducts at tips of papilla in 20 to 40% of the children. In females, because of the short urethra, any trauma to the urethra during sexual intercourse facilitates the entry of bacteria into the bladder. So acute pyelonephritis macroscopy shows one or both kidney may be involved and may be normal or enlarged and swollen renal surface, and the cortex shows multiple discrete yellow-white abscesses measuring several millimeters in diameter. So the microscopy shows early suppurative necrosis limited to interstitial tissue, but later, as the abscess rupture into the tubules, it gives rise to white cell cast in the urine glomeruli not affected. So the complications of acute pyelonephritis. The main complication is renal papillary necrosis, an infrequent form of pyelonephritis seen in diabetes, urinary tract obstruction, analgesic abuse, and sickle cell anemia. So the morphology shows sharply defined gray-white to yellow necrosis of apical two-thirds of the renal pyramid. The microscopy shows one or all papillary tips show coagulative necrosis surrounded by neutrophilic infiltrate, pyonephrosis. When pus fills the renal pelvis, calyx, and ureter in case of obstruction, resulting in perinephric abscess, that is collection of pus in the perinephric tissue. So chronic pyelonephritis, interstitial inflammation, and scarring of the renal parenchyma are associated with grossly visible scarring and deformity of the pelvic calyceal system in patients with a history of urinary tract infection and is an important cause of chronic renal failure. So it can be a chronic obstructive pyelonephritis, or the obstructionist predisposes the kidney to recurrent infections, inflammation, and scarring, bilaterally with the calculi and unilateral obstruction lesions of the ureter, chronic reflex associated pyelonephritis, that is known as reflex nephropathy. More common form results from superimposition of a urinary tract infection on congenital vesicoureteral reflex and intrarenal reflex. The resultant scarring and atrophy of one or both kidney leads to chronic renal failure. So chronic pyelonephritis macroscopy shows one or both kidneys may be involved, either diffusely or in patches. Hallmark is scarring of the pelvis or calyx, or both. So leading to papillary blunting, dilated calyx and marked calyceal deformities, uneven scarring, differentiated from more symmetrically contracted kidneys associated with benign nephrosclerosis and chronic glomerulonephritis. So the chronic pyelonephritis microscopy shows mixed inflammatory infiltrate involving calyceal mucosa, wall, and tubules, and interstitial fibrosis and tubular atrophy. Some dilated tubules contain pink to blue, glassy, positive cast that suggests thyroidization. Thickened, hyalinized vascular walls, glomeruli may be normal or shows periglomerular fibrosis or hyalination. Next, tuberculous pyelonephritis. So hematogenous spread of TB from the lungs or other sites, ascending infection from genitourinary, that is tuberculous miliary T. So next is drugs-induced tubulo-interstitial nephritis. So it has two forms. Acute drug-induced interstitial nephritis. Acute in the sense it is most frequently occurs with synthetic penicillin, other synthetic antibiotics like diuretics, thiazide-like diuretics, or non-steroidal anti-inflammatory drugs, and numerous other drugs like phenidone and cimetidine. Chronic interstitial nephritis is often associated with renal papillary necrosis, pathogenesis, and immune mechanism suggested on the basis of clinical evidence of type 1 hypersensitivity, so which includes eosinophilia rash and raised serum immunoglobulin E levels. Mononuclear or granulomatous infiltrate together with positive skin test to the drugs suggest a T-cell mediated type 4 hypersensitivity reaction. Moving on to the disease of the vessels. So under the disease of the vessels, we have renal artery stenosis. So renal artery is the main artery supplying to the kidney. So if there is a stenosis, or that means narrowing or complete occlusion of one or both renal arteries, it is defined by radiography imaging at greater than 60% of stenosis on renal Doppler or greater than 50% on angiography. So to rule out the renal artery stenosis, we'll go for renal Doppler or renal angiography. If it shows more than 60% or 50%, then it shows confirm the renal artery stenosis. So ischemic nephropathy. So ischemic nephropathy is a chronic reduction in GFR, that is glomerular filtration rate, that occurs from a narrowing on the renal artery. RVHTN, that is renovascular hypertension. So it is a hypertension mediated by high levels of renin and angiotensin II, which is produced by an underperfused kidney behind a stenosed renal artery. So the angiography shows a severe stenosis of the renal artery. So to conclude, so the pathology of the kidney is organized into 4 anatomic categories: diseases of the glomeruli, diseases of the tubules, interstitium, and diseases of the vessels. So diseases that affect the glomeruli often have an immunologic etiology, whereas those that affect the tubules and interstitium usually have an infectious or toxic etiology. So early in the disease process, most disorders predominantly affect one of the anatomical structures listed above. So over time, however, the entire kidney usually becomes diseased. So because of the large physiological reserves of the kidneys, many diseases do not become clinically apparent until the majority of the organ is affected, making the subtle abnormalities in laboratory findings the only early indication of renal disease. So recognition of these patterns of abnormalities, pathological findings, and clinical presentation is perhaps more important to renal pathology than any other organ system. Thank you.